Because we have such an immense volume of information to unpack today, we're going to use this roadmap to make sure we don't miss a single beat. We're covering 1. Anatomy, 2. Foreskin and congenital anomalies, 3. Trauma, 4. Acquired conditions, 5. Cancer, and 6. Rare pathologies. All right, Section 1. Anatomy of the urethra, the blueprint. We absolutely have to understand the normal baseline before we can figure out what happens when things go wrong, right? So, the male urethra is typically about 18 to 21 centimeters long, and it's divided into 4 very distinct sections. First up, you have the prostatic urethra, which is the most distensible, meaning it stretches the most. Next is the membranous urethra. This part pierces the urogenital diaphragm, making it both the shortest and the least distensible portion. Then we get to the bulbar urethra, which is incredibly important to remember because it's the most commonly injured part during trauma. And finally, the penile urethra, which makes up the longest portion. Oh, and a quick pro tip to mentally file away, the external meatus right at the very tip is actually the narrowest part of the entire tract. Now, this perfectly highlights a brilliant anatomical contrast between the male and female urethra. You see, the female urethra is much shorter, just 3 to 4 centimeters. And this exact anatomical difference directly dictates clinical risks. For females, that shorter length means a significantly higher risk for urinary tract infections, but a much lower risk of physical trauma. On the flip side, the much longer 18 to 21 centimeter male tract basically flips those odds. They have a lower UTI risk, but a significantly higher risk for structural urethral trauma. It's just simple plumbing, really. Moving right along to Section 2, foreskin and congenital anomalies. Okay, let's clear up 2 very common foreskin conditions. Phimosis is simply the inability to retract the foreskin. Simple enough. Paraphimosis, on the other hand, is when a retracted foreskin forms a tight, painfully swollen constriction ring around the penis. And just between us, paraphimosis is kind of famous in hospitals for happening when a brand new medical intern inserts a Foley catheter and then totally forgets to pull the foreskin back over the glands afterward. Yikes. Next up is hypospadias. This is the most common congenital urogenital anomaly, where the urethral opening is located on the underside, or ventrally. Now, surgical repair for this is best done early, between 6 to 12 months of age, before the child develops genital awareness. There are 4 core principles for this repair. First, orthoplasty, which corrects the downward bend, or core D. Second, urethroplasty, where you reposition the opening and actually tubularize the urethra. Third, glandoplasty, to reconstruct the glands. And fourth, skin cover. The absolutely crucial takeaway here, circumcision should never be done first. Why? Because you absolutely need that precious foreskin tissue to create the reconstructive skin cover later on. Let's rapid fire 2 more severe congenital anomalies before we move on. First is ectopia vesicae, also known as bladder exstrophy. Think of this as an exposed bladder, and it's caused by a deficient lower anterior abdominal wall. Second is posterior urethral valves. This is exclusively seen in males and causes recurrent UTIs by acting almost like a one-way blockage. If you look at a prenatal ultrasound, it classically shows what we call a keyhole defect. So mentally anchor those 2 phrases, exposed bladder and keyhole defect. They are classic, immediate spot diagnoses. Section 3, urethral and penile traina. What's really fascinating here is how the physical mechanism of an injury perfectly predicts the exact anatomical location of the trauma. Notice the stark contrast. Proximal urethral trauma is almost always secondary to a pelvic fracture. This causes deep internal bleeding and a deep perineal hematoma. If you perform a digital rectal exam, you'll actually feel a floating or high-riding prostate. That's known as Vermeuten's sign. Distal urethral trauma, however, usually comes from a straddle injury. Think of a jockey hitting a saddle hard, or someone slipping and stepping onto a flipped manhole cover. This causes a much more superficial butterfly hematoma across the penis and scrotum. Now, both will present with an inability to pee, but the physical signs are completely dictated by how the injury actually happened. And this brings us to a massive, absolutely crucial clinical warning. The emergency rule is this: never, ever catheterize a suspected urethral tear. Just don't do it. If a trauma patient comes in, there's blood at the meatus, and they have a full, painful bladder, forcefully pushing a Foley catheter in is incredibly dangerous. Why? Because you can take a partial tear and turn it into a catastrophic, complete tear.
Instead, the standard of care is to bypass the urethra entirely by doing a suprapubic catheterization, or SPC.
Okay, let's talk about penile trauma, specifically a fractured penile shaft. This happens when the penis is erect, most commonly during intercourse. The patient will classically tell you they heard a very distinct, audible popping sound, which was followed by immediate flaccidity. What's happening is the tunica albuginea, the tough white covering of the erectile tissue, actually tears. And by the time the patient gets to the ER, the extravasated blood has created this highly visual, dark purple swelling known as an eggplant deformity. It literally looks just like an eggplant. This requires urgent surgical evacuation of the hematoma to repair that torn tunica.
Let's keep our fast pace going. Section 4, Peyronie's disease and priapism. First in this category is Peyronie's disease. This condition is caused by a calcific deposition or a plaque forming inside the corpora cavernosa. What that does is cause a painful bend in the penis, especially when erect. If medications don't work, it's surgically corrected using Nisbet's procedure, where they essentially place a suture on the opposite side to counterbalance the bend. Fun historical anecdote for you, our medical sources point out that former U.S. President Bill Clinton's implication in the Monica Lewinsky scandal famously involved a unique anatomical characteristic that matched this exact bending condition. Pretty wild, right? Next up is priapism, an erection lasting for more than 4 hours. It's super important to contrast the two distinct types here. Ischemic, or low-flow priapism, is caused by a venous outflow block. This one is highly painful, filled with dark deoxygenated blood, and is a true surgical emergency. It requires adrenaline injections or surgical shunts to stop tissue necrosis. On the other hand, non-ischemic or high-flow priapism is caused by too much arterial inflow, like from blunt trauma or a papillary injection. This type is painless, filled with bright, oxygenated blood, and generally is not considered an immediate surgical emergency.
Section 5, Managing Penile Cancer.
Let's see how our clinical foundation builds up to oncology. Penile cancer is usually a squamous cell carcinoma, often linked to a p53 gene mutation. But before it becomes fully invasive, you'll see pre-malignant precursors. First is Bowen's disease, which affects the shaft and looks kind of like a reddish, sunburned papule. Then there's erythroplasia of Quirat. This looks very similar to Bowen's, but it's specifically located on the glans. Finally, we have the Buschke-Lowenstein tumor. This is a slow, outward-growing variant driven by HPV, and it actually carries a notably better prognosis than the others.
Now, surgical management for these cancers comes with some highly specific non-negotiable rules. You absolutely must ensure a 1 centimeter healthy tissue margin around the tumor. But just as crucially, you must ensure that at least a 2 centimeter penile stump remains. The logic here is super practical. The patient needs that 2 centimeter stump so they can stand and manually direct their urine stream. If you can't save that 2 centimeter stump after taking the margins, a partial procedure just won't work. In that case, you have to do a total amputation, paired with a perineal urethrostomy, which means the patient will need to sit down to void going forward.
And here it is, the absolute #1 takeaway regarding penile cancer outcomes. The single most important prognostic factor is inguinal lymph node status. The penis drains directly into these nodes. If the cancer spreads there and starts eroding the femoral or iliac vessels, that massive catastrophic hemorrhage becomes the most common cause of death in these patients. It is absolutely critical to monitor. All right, Section 6, Rare Urethral Pathologies.
Just to make sure we leave absolutely no stone unturned in this crash course, let's hit 2 highly specific, rare spot diagnoses. A urethral caruncle is a fleshy, raspberry-like vascular swelling that pops up in the posterior urethra of elderly women. It's very vascular, so it often presents with spontaneous bleeding. Then we have Fowler syndrome. This is a functional obstruction that causes urinary retention because of abnormal sphincter myotonia. Basically, the sphincter muscle can't relax. It's a really specific condition, most characteristically seen in young women diagnosed with polycystic ovary syndrome, or PCOS.
And there you have it. We've covered some incredible ground today in this rapid-fire explainer, navigating all the way from the foundational anatomical blueprint straight through to complex oncology. So I'll leave you with a thought to chew on. How does understanding this exact anatomical blueprint completely change your perspective on how you manage those terrifying, time-sensitive urological emergencies? Thank you all so much for keeping up with a fast pace today. Keep reviewing these clinical markers, and we'll see you in the next explainer.